Hello, hi everyone. Can you hear me?
Yes.
Hi, I see some familiar faces. I'm Max Smolkin. I'm one of the internal medicine doctors here at St. Anthony Summit in Frisco. And I was invited to give you guys a basic talk about how is living in high altitude with oxygen related issues. I grew up in Patagonia in Argentina, in a small town like this. Did my medical school in Argentina and came to the US to do research at University of Colorado. I was invited to do some research in cancer at Anschutz. And after that, I did my residency in internal medicine there, became faculty there, and was working with residents and students. And after that, Denver became too big for me. I lived there for 10 years, from 2007 to 2017, and there was a drastic change. And it pushed me back to my roots, to be back in the mountains, to be in a small town. And I moved here approximately 6 years ago. And during that time, I practiced medicine here, and I completed my fellowship at University of Colorado also, Wilderness Medicine Division, and I specialized in high altitude. And this is the perfect place to do that work. So I'm here to kind of like talk about mostly about what are we gonna see in a few years in our bodies if we stay up here, okay? So the basic of the pathophysiology or how things work in our body in high altitude is different than at sea level. So I'm going to try to explain a little bit of that, okay? So I just came back from Peru 2 days ago. I was climbing there. I reached 20,150 feet without oxygen. And so I can talk in first person how bad it is to be at that altitude rather than just telling you what the book says, okay? This is what we summit, Chopicalqui in Peru. And let's get started and talk a little bit about how our bodies adapt to high altitude. So by definition, what is high altitude? So high altitude is anything above 1,500 meters, okay? So that's like 4,900 feet. So Denver is already high altitude. Then we can divide high altitude in 3 stages or levels. You know, high altitude from 1,500 to 3,500 meters. I'm sorry I'm talking in meters, but that's international consensus. Everybody in the world uses meters. but I align it here in feet so you guys have a better understanding. And then very high altitude is 3,500 meters to 5,500 meters. And there's only few populations in the world that live at that altitude, like towns and settlements. One of them is in Peru called La Rinconada, that is around 5,000. And then extreme altitude, that is what we encounter when we go to Everest, for example, okay? So we've seen a huge phenomenon here, like the population in the Rocky Mountains has doubled in the past decade. We are the lucky ones. We are the lucky ones that can move to such a beautiful place like this, that is unique in the world, in the sense that we have all the resources that other high altitude places in the world don't have. If you go around the world and you go to the Himalayas or you go to the Andes, there's no population like this, where we have full hospitals, we have services, we have first world, accommodations and everything. So it's a phenomenon that we're seeing, that people from low sides of the world are moving here, and more after pandemic. I don't know if you noticed that, but in this last 3 years, the county has exploded. And people that had second homes, suddenly those second homes, some of them start moving here. And a lot of people that come from other states, they just look at Colorado and Summit County as a very beautiful place to retire and to live, but they were not aware of the effects of high altitude in the long run. So that's something as providers we're dealing with, and that's one of the main reasons why I'm here talking, to bring some awareness, okay? 700,000 people live about 2,500 meters in Colorado alone. And this may be outdated. This may be data from 2 years ago. And so some of the people that come to high altitude already have pre-existing conditions, heart and lung predominantly, and that's something that, you know, we need to start talking about. What are we going to do when we start seeing complications if we don't take care of ourselves while we live out here? So let's talk a little bit. There's this misconceptions about how much oxygen is in the air and all this like theories, but this is, I'm trying to simplify here. What's the altitude and oxygen concentration dilemma, okay? So some people, if you don't know, atmospheric pressure is the pressure of the column of the air above you. So if we are at sea level, an average of 24 miles from sea level up is what we have of air, you know, above us. If you go higher, that distance shortens, okay? So we're pretty high up here. And this atmospheric pressure decreases as we go higher, okay? Now, the air at elevation, the percentages of gases in the air is the same, oxygen, nitrogen, and CO2. So the percentages don't change. But as you know, a percentage is just a number and depends on the bigger number, right? It's not the same, say, 10% of 10 or 10% of 1,000. So the air at elevation has the same percentage of concentrations, but with decreased partial pressures due to lower atmospheric pressure. So that concept is what triggers all these issues with oxygen up here. And I want this to be clear. We're not going to go very in depth into pathophysiology, but these are the concepts that I want you to take home, okay? Partial pressure of oxygen is the pressure that the oxygen is applying to the alveolar sac walls, those little sacs that we have inside your lungs, and it's pushing oxygen into the bloodstream. So the lower the partial pressure of oxygen, the lower the amount of oxygen that's going to go through that wall, hence the lower the oxygen you have in your bloodstream. So although the percentage of oxygen in the air, if you compare the entire mass of gases, is the same, is the pressure that we have to push oxygen inside your bloodstream. What gives you the low oxygen saturation when they check your blood. So here is a graph that is kind of like showing that average sea level pressure is 760 millimeters of mercury, and that's the partial pressure of oxygen, 160. If we go up to Mount Everest, the pressure changes and the partial pressure decreases to 53. So here we're pushing oxygen with this pressure into your bloodstream, and here we're just pushing with 53. This is a third. So, you guys get the picture, kind of? Okay. Because this is a concept that a lot of people, you know, has issues grasping, and so with a graph and explain a little bit about the composition of the gases is important. So, as barometric pressure falls with increasing altitude, the partial pressure of oxygen also decreases. And then we have the primary insult of high altitude. And this word you're going to see a lot, hypoxia. Hypo is less, oxia, oxygen, okay? So hypoxia is something that we doctors tell patients all the time. You go to a clinical visit, we check your vitals, and you can maybe listen to the nurse telling the doctor, patient is hypoxic. The oxygen saturation is below 90%. 85, 87, 88 people, right? That's what we refer with the term hypoxia. low oxygen levels in your bloodstream, okay? So what happens to our body when it senses hypoxia? We have a lot of sensors in our body that is raising the red flags to different systems saying, hey, we need more oxygen. We have low oxygen levels in blood, so what are we going to do about it? So the human body tries to adapt and it starts kicking different systems to get more oxygen into the bloodstream in order to deliver that oxygen through the blood to the different tissues, brain, kidney, lungs, heart. So one of the things that we do is increase ventilation. So ventilation is get air moving. So if you notice, if you're coming from a sea level, you may have a respiratory rate, that means how many respirations per minute, that is pretty comfortable. Maybe 10 respirations to 15 per minute. When you come to high altitude, that increases, and you start breathing harder and faster. That's because you're trying to get more air circulating into your lungs to get more oxygen in. So that's ventilation. So ventilation increases, and as you start breathing faster, sometimes deeper, you get rid of CO2. That's the exchange, right? You get oxygen in and you're trying to get CO2 out. Well, as every mechanism of compensation, there's pros and cons. We try to do something good that is getting oxygen in, but you get CO2 out. That to the point that we become hypocapnic. That means low CO2 in your body, and that will regulate your pH. The pH in your blood is telling you how acidic or alkaloid is your blood, and that number will dictate a lot of metabolic decisions in your body, okay? So as we try to get more oxygen in, we take in CO2 out, we become hypocapnic and alkalotic, and now the kidney has to kick in. So it's a cycle. We start triggering systems, and the ventilation is one of the first things that happen to you to adapt to high altitude, and the kidney takes 2 to 3 days to kick in. So there's this phase of adaptation that takes a couple days, and now what is the kidney going to do? Hey, you got rid of a lot of acid, CO2. To equilibrate, I have to get rid of bicarbonate. So we start peeing a lot. So I don't know if you realize that when you come to high altitude after being on vacation in the sea level, or is your first time in high altitude, people sometimes become dehydrated. It's not only because they don't drink enough water, but because they start peeing a lot. This is one of the parts of the cycle, your body trying to adapt to this, okay? Get rid of CO2, get oxygen in, and then you start peeing bicarbonate out, okay? That's one of the first things that your body does, the ventilation. What are the effects of hypoxia on circulation? That means blood going through your entire system. So the idea is to move more oxygen through the blood. So if at sea level, let's put just dumb numbers. One cycle of blood through your body is circulating 10 molecules of oxygen. When you are in high altitude, you're only circulating 5 molecules. You're going to try to repeat that cycle at the same time, twice, to try to equilibrate, right? So your circulation is about moving oxygen, and if I don't have enough, let's move it again. Let's move it again and go through the lungs and get more oxygen. So the idea is to move oxygen from the lungs to your tissues. Main tissues, brain, kidney, heart, lungs. Okay. Now, the circulation could be systemic, and that's the entire body, and that will increase your heart rate. So when anybody been going to a 14er, You're just walking and your heart rate goes up to 150, 160. That's what's going on. Your body is trying to circulate faster to get more oxygen. And let's do it again, and let's do it again. And that's how we get agitated and our heart rate goes up. And then you go to sea level and you're able to walk in the beach and your heart rate may be 70. Because we have plenty of molecules of oxygen going around. So increases your heart rate. That can increase your blood pressure. And we're going to talk about that a little later. Heart rate and blood pressure also, will take you to have an increased cardiac output. Cardiac output is how much blood are we pushing out of your heart to reach, your organs. So all these three things that happen, heart rate, blood pressure, and cardiac output, will definitely increase the pressures in your right heart. And this is something that we're going to talk in a little bit, and that's one of the main things that I want you to take home, because it's one of the things that we're going to be checking as doctors on everybody that lives out here. How's your right heart doing after living in high altitude for years? Okay? Because when your right heart starts increasing pressures because it's working harder, you develop what we call pulmonary hypertension. Okay, and we'll talk about that in a little bit. But circulation systemic, increased heart rate, blood pressure, cardiac output, put more stress on the right heart, and you can develop pulmonary hypertension. Now, what about the circulation in your lungs? So, the circulation increases, and this PVR thing is the pulmonary vascular resistance. So, let's imagine you're a skinny guy like me, you don't have much muscle. You go to the gym and you start introducing a stressor. A stressor will be your weights, right? And every day you add more weights. You're gonna start having an increase in your muscle mass, okay? You're putting more pressure to those muscles, and every day, it's less work for you to lift harder weights, but you're seeing changes in your body that are adapting to that. Same thing happens with your lungs. The more circulation you have, you increase the resistance on the vasculature, those veins and vessels in your lungs. That's a response from the hypoxia, from that low oxygen. And then you start constricting those vessels. So that's what we call hypoxic pulmonary vasoconstriction. And that also increases the pulmonary artery pressure. So I don't have a graph of the heart here, but if you imagine the heart is having 4 chambers, the right side of the heart, the right atrium, receives blood and then pushes it out through the right ventricle to your lungs, through the pulmonary artery, to exchange the gases in the lungs. That pulmonary artery starts getting bigger and bigger because the pressure that has to overcome through the lungs because of this vasoconstriction is bigger and bigger. So we end up again, possible issues on the right side of your heart because of low oxygen, increased circulation of your lungs, and vasoconstriction. And then what happens in the brain? So a lot of people that comes to high altitude, acutely they have headaches. So low oxygen or hypoxia can trigger vasodilation, so those vessels get big, or vasoconstriction. This thing, gives a lot of people the headaches, high altitude headaches. So there's no, the autoregulation of this is impaired in high altitude. And a lot of people, and there's some studies that show that some people get some decline, cognitive decline in high altitude after many, many, many years. So that has to do with the chronic hypoxia, chronic oxygen depletion. So I've seen in the hospital, I have a lot of visitors. They come to the hospital, they stay with us for any other reason, let's say pneumonia or cellulitis, an infection of the skin. And family shows up at the hospital and they say, you know, he's not acting right. He's a smart guy, he's an engineer. And he's not answering questions as he should, and you know, different tasks are not being accomplished the same way. And then we check, you know, blood oxygen levels, and as soon as we put them on oxygen, they go back to their baseline. So, you know, oxygen, there's no big science there. You need oxygen in your brain to think through, but then we'll see patients that move to high altitude that are lacking oxygen, or they're being prescribed oxygen and they don't want to use it. You can see a little bit of a decline in the mental condition. That has to do with, you know, maybe chronic vascular issues they had before, that at low level, sea level, they will not show up. Okay. So now let's talk about blood. What happens with blood? And maybe a lot of you know about this, but there's been anti-doping in the Olympics with people, you know, injecting EPO. Have you heard about EPO? And that's the substance we have in our bodies that is secreted by the kidneys to produce more red blood cells. And there's been people at sea level injecting EPO to produce more red blood cells in order to carry more oxygen to the tissues and perform better, right? Well, we don't need EPO up here. We're going to produce plenty of this. But EPO, as I said, is produced by the kidneys. The idea is to increase the hemoglobin, and that's the carrier of oxygen in your blood. So, on the other hand, if we produce too much of that, because we're in a chronic hypoxic state, a chronic lack of oxygen, then we can make things worse. We want to produce too much of that, and the blood gets more viscous, thicker, right? And that viscosity doesn't help at all transportation of oxygen. So yes, we see that people that have been here lifelong or long-term residents, their hemoglobin numbers start going up, higher than people at low, you know, altitude. And there's certain numbers that we can monitor as doctors that do not need intervention. But there's other numbers that get so high that we need to intervene. And that's something that I will talk in a little bit. It's called chronic mountain sickness. And there's a lot of people that don't know anything about this, including a lot of doctors, because we focus on the acute mountain sickness usually, but we don't really talk about chronic mountain sickness anymore. And then we'll touch base on that. But basically, these are the things that your body will do when it senses hypoxia. Ventilation, circulation, and changes in your blood. Now, I want to retire here. I have 2 kids. I have a 2-year-old and an almost 5-year-old, and I want to stay here. So I need to, you know, pass this information to everybody that wants to stay up here, be healthy. And I need to tell you what's the worst case scenario. What are the problems that we'll see in long-term residents if they don't get, you know, follow up with their doctors and see what are the things going on in their bodies. So the serious complications that are purely related to high altitude, let's erase any other pre-existing conditions that you may have. Okay? Let's imagine we're all perfect, we don't have any medical issues that come with age. But what are the things that purely are related to high altitude in residents? So one thing is called a re-entry HAPE. Re-entry, high altitude pulmonary edema. That's fluid in your lungs
related to high altitude exposure. We have high altitude pulmonary edema that usually happens in people that come to high altitude without any type of acclimatization. And the numbers that we see are pretty high nowadays because we're in a first world country where you can take a direct flight from Florida to Denver, catch an epic ride, and at noon you're skiing at 12,000 feet. And we see this all the time. We see tourists take a red eye from Florida, arrive at 7 in the morning in Denver, catch the epic ride. I pay for a week, I have my Airbnb. I can't get in my Airbnb until 4 p.m. So I'm gonna go skiing. Oh, wait, I love those IPAs. Awesome Colorado IPAs, not 9.5% alcohol. And I'm tired, I'm okay because I already pay for all this. Let's go up there and then get tired on less than 12 hours arriving in high altitude. I'm gonna hit the hot tub. And my cousin told me there's really good pot here. So I never do pot, but you know, I'm in Colorado. So let's get everything done in less than 12 hours. And then I will end up seeing this funny guy with a funny accent in the hospital that is telling you have the Summit County syndrome. So this is exactly what happens in winter. You get all these things going on at the same time, people pass out all the time, but mainly this wouldn't happen if you acclimatize. So I will recommend, the only way to, avoid having high altitude pulmonary edema of re-entry, and re-entry is because you already live here. So you go on vacation to Jamaica, you spend 3 weeks, 2 weeks, whatever, you come back, and then your body is at risk for re-entry. Hey, now, by the age of the people here that are very young, I'm telling you, this is for the very, 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 very young. So it's more prevalent in adolescents and young adults than in older folks. But you all have family members, so I must tell you, I've seen nasty re-entry hate. So what I will say, if you go for extended time, vacation to sea level, come back, spend at least one night in Denver, that's halfway, and then drive up and see how you do. Okay. And then the first 24 hours when you arrive, don't go on a hike or a mountain bike ride or any of that, just chill. Okay? And then we have the other stuff, that is the chronic mountain sickness. And this is very important because the prevalence is increasing. And we'll see a lot of cases in Leadville, although I know socio-economical determinants of Leadville versus Summit are very different. And I've received patients from Leadville, and I know living situations are tougher for many, many reasons. But the chronic mountain sickness is determined by genetics. So nobody is accepted, We're not made. We all here in this room, I can tell, I don't see any Himalayan faces here. But we're not made for this altitude. Even the people in the Andes, in Bolivia and Peru, that live at very high altitudes, they translocated from sea level to high altitude in a matter of hundreds of years. So they were not able to develop the genetic changes to adapt to that high altitude. They acclimatized, but their bodies are not fully adapted to high altitude. Compared to the Himalayas, that have been there for thousands of years, and they carry those gene changes that adapt to those levels of oxygen. Even the Himalayas, half of the people are not from that genetic group. They're coming from China, lowlanders moving up. Those are the ones that we see the difference in numbers. So chronic mountain sickness is a severe type of hypoxia. So that means you've been living with low oxygen levels for years. and your production of red blood cells and hemoglobin is extremely high. What is extremely high? A hemoglobin of greater than 19 or 21. 21 in men and 19 in female. Now, I throw those numbers there because I'm sure there's going to be people asking for the labs. I say, hey, I got a hemoglobin of 16. What should I do? Chronic mountain sickness, it's extremely high numbers, 19 to 21 in hemoglobin, and that's one of the main diagnostic criteria. And we have to exclude other chronic issues, so the patient doesn't have chronic obstructive pulmonary disease, for example, or congestive heart failure. So that means it's purely an issue of blood and oxygen levels. And it's characterized by people getting extreme fatigue. Extreme fatigue. They just not functioning well. They have, congestion of their veins. They have big veins in their legs. They have a lot of congestion in their chest when you take an X-ray because of that pulmonary vascular constriction and congestion. They're slow, mentally slower. And this is not what happens to everyone. I don't want to, discourage you from giving up here. This is around 5% of the people. Okay, 5% is not a small number, but it's not everyone. Okay, so there's a high incidence in Leadville. Usually it's males over 40 years old. And good news for the ladies, you are a little bit more protected than us. Why? Because you auto-regulate yourself with what we call natural phlebotomy, menstruation. So every month you get rid of some blood that we can't. So you try to keep those numbers lower, and then you have a hormonal, progesterone that may protect you. There's some studies about it. So it's more prevalent in male than in female. Now, when we cross that 65-year-old mark, numbers tend to get equal. Okay. One of the things that we do for chronic mountain sickness that we used to do is phlebotomies. So you go to the doctor, they tell you, hey, those numbers are very high. Let me call the vampire and take a couple of units. Well, that's just a Band-Aid. We know that those numbers are going to go up again as soon as you stay in high altitude. And you continue with that hypoxia, with that low oxygen level. That's very important. If we can modify that, and your oxygen levels are normal, or at least closer to normal, all that cascade of circulation, blood, and ventilation gets interrupted, and the EPO may go down, and you may produce less red blood cells and hemoglobin, right? Now, what's the only cure for chronic mountain sickness? Relocation. And it's true. Until we start doing some research studies right now with acetazolamide or Diamox that was initially intended for acute mountain sickness, not chronic. So we usually give it for short term. You're going up, you take it until you get to the highest point, and then you start weaning off or stopping it. And now there's some studies showing that we may have some room for acetazolamide in the chronic term. But the main thing is we gotta get rid of the insult, the low oxygen. So now we have, many resources for oxygen that we didn't have before. So that's one of the things. And then the last one is the pulmonary hypertension or right heart failure that I kind of mentioned before. And the decrease, partial, arterial oxygen in your lungs will, increase your CO, cardiac output, and that will increase your pressures in your artery, pulmonary artery. How do we follow those pressures? With an echocardiogram, the ultrasound of your heart. So it's not a bad idea that if you have a PCP, a primary care physician, and you start having some issues with breathing and functioning and cognition, check a CBC. That means a complete blood count to take a look at your red blood cells and hemoglobin. And then talk to your doctor, hey, is it indicated for me to have a baseline echocardiogram? More so if you already have some cardiac issues at lower altitudes, to compare before and after and see how's the altitude affecting you. Is those pressures are going higher or not? If your pressures of the right side of your heart compared to a couple years ago are the same, you're wearing oxygen at night, for example, and you're feeling good, you're going the right way. You have some peace of mind, and you know things are not going to get worse. So I think it's a good idea. It's non-invasive. It's an ultrasound like they do for the babies, but in your heart. And it will give very valuable data to the doctor to see how close follow-up you need, and take care of the issue before somebody tells you it's too late, you need to go down. Hey, I already bought a $2 million house. and I don't have a short-term rental permit in this county. So I think those are things that we need to think about, because this is reality and we love this place, but there's certain hurdles that we have to think about. So.
May I ask you one question?
Yeah.
How do you measure the right side of your heart?
So an echocardiogram, an ultrasound, will measure dimensions and will also measure pressures. It will take a look at the jet of going in and out, and it will measure pressure. So the tech will send those to the cardiologist, and the cardiologist in the report will say, pulmonary artery pressure, so and so, and will give you a number, okay? Those numbers are, mild, moderate to severe, and based on that, depending on the reason why you have right heart pressures that are high, it will be the treatment. I don't want to go into there's five groups of pulmonary hypertension. Don't want to go through all of them, but one of them is the chronic hypoxia related to altitude. So they may say, after I rule out all the other causes, this is more likely to be high altitude and hypoxia, you need oxygen. And they will do also sleep studies. That's another thing that is very important, I think. I have sleep apnea, and my wife was able to tell me that. I'm a doctor, I don't have any medical issues, right? And she's a doctor, so she told me you have sleep apnea. And I got a sleep study, and that's very important because that gives you another perspective of what are the things that are really happening in my body that I'm not aware of, that I can act on and prevent from issues in the future. So, but yes, ultrasound will measure cavity, walls, thickness, and pressures. So, other medical concerns on high altitude, sleep disorders. If you tell me you sleep better in high altitude than at low altitude, let me know because I will study you. It's impossible. It's impossible. So, we know that, we shift from a deeper sleep to a lighter sleep when we come to high altitude. We have increased arousal, in the middle of the night. Any tiny thing that will not bother us at low altitude will wake us up. And then one of the things that the body does to acclimatize is the periodic breathing. Periodic breathing, and maybe if you guys are here with your partner, maybe tell you if it's like this, but because of the ventilation and you try to get more air circulating, you get into this really, really fast breathing in crescendo that goes like this. Then you have a pause. And then you go again. That is what we call Kussmaul breathing or periodic breathing. What your body's trying to do is to get more oxygen in your lungs to the point that you get rid of that CO2, and then another sensor goes, hey, wait, there's not enough CO2. Stop breathing and build that up. And that's when you stop breathing and you have this apneic episode. And then, hey, it's too much, stop breathing again. And you go like this. So this periodic breathing is something that usually happens when you come from low to high altitude in the first 4 days or so, and then it gets better. Acetazolamide or Diamox is one of the medications that we use for people coming out for short term. That helps with that, but it could be disruptive. You don't have a good night's sleep when you go into the cycle. You may wake up asking for air, you know. So that's because of the hypoxia, you know, your low oxygen levels, and triggers all this periodic breathing. It's not abnormal. It's a normal response, but it's not comfortable at all. Obstructive sleep apnea. If you already have obstructive sleep apnea, that means there's an obstruction in your airway of some kind. Things are not going to get better in high altitude. Because the sleep apneas that we have in high altitude are central sleep apneas, most likely. That's your brain managing your breathing at night. If you add that you have a shortcut in your motherboard and a hardware problem, you have issues. You have two things that are preventing you from breathing well at night. So people that have sleep apnea should use their CPAPs here in high altitude to get rid of that obstruction, or have surgery like I did, septal repair and tonsillectomy to try to open on that turbo there to get more air. And that's not going to take care of the central sleep apnea. But central sleep apnea can be decreased if your body senses good oxygen levels. So don't get me wrong, I want to be very clear. Oxygen in your room will not take care of obstructive sleep apnea, because you need force to overcome that obstruction. Although, if you need oxygen and you only have central sleep apnea, your body's sensing that you have good oxygen levels and will not go into periodic breathing, and things are going to get better. Now, a lot of people up here use CPAP, and they put oxygen on the machine, right? So if you already have oxygen in your room, you may not need to put anything on your CPAP. And if you take care of that obstruction with surgery, who knows, you may be able to get rid of the CPAP. So there's a lot of research going on in this. There's other devices other than CPAP, but I just want to be very clear. Obstruction is one thing, central sleep apnea is another thing, okay? But both together are really bad combination, and it's going to give you trouble in the future with your heart. It's going to increase the pressures on your right side, and you may end up having congestive heart failure from right side failure, okay? So then other things like alcohol at high altitude. There's been several studies about that. Alcohol doesn't get potentiated in high altitude, but because of the combination of the deprivation of oxygen up here and ventilation response when you're intoxicated, things get worse. There's been several studies done by the Air Force back in the 50s and 60s where they used to put drunk pilots in airplanes taking up to 8,000 feet. But measuring alcohol levels, that's the fun part of the research back in the day. But then immunosuppression, and this is important, immunosuppression in high altitude. So there's been a lot of documentation about bacterial infections in high altitude. It's been studied, and we have impaired T lymphocyte function. The T lymphocytes are some of the cells that deal with infections, and I can tell because I've been practicing in lower altitude and here. An infection like a cellulitis, a bacterial cellulitis, may take 24 hours with IV antibiotics at lower altitude, and here it may take 48 hours to 72 hours to start seeing changes. With things that hypoxia, in high altitude, affecting the T lymphocytes, and infections may take longer to resolve in high altitude. And then if we talk about infection in your lungs, of course it's going to be, harder because it's harder to breathe up here. And then, coronary artery disease, hypertension, arrhythmias like atrial fibrillation, anemia, and all those diabetes, all those are a little harder to control up here. That's why it's encouraged that if you have any of these issues and you translocate from a lower level to a higher level, get a checkup sooner than later, see how your numbers are doing, see if we have to tweak your medications to adapt to high altitude, and you may need to de-escalate. If you live half year here, half year lower levels, like a lot of people do, it's not unusual that patients will go back to Florida in winter and they call me, hey doc, you increased my blood pressure medication and now I'm here and I'm woozy and my blood pressures are lower, so my doctor lowered the dose. Yeah, it's expected. So the other thing is acid reflux. High altitude increases acid reflux. And there's been cases of ulcerative, peptic ulcer disease in high altitude. So, pay attention to those, acid reflux things and make sure that you don't have complications in the future. So, oxygen therapy, since the hypoxia is the main factor driving complications at high altitude, it makes sense that we use oxygen as part of the main treatment for these complications. A lot of people have severe complications at high altitude cerebral edema or high altitude pulmonary edema, or acute mountain sickness. The first thing we do when they arrive to the ED, we put them on oxygen. If putting them on oxygen is not helping quickly, we send them down to Denver, because that's the main therapy. These are acute issues, but we know oxygen works. It may take a couple of hours, and then we'll see somebody checking in the ED with a saturation of 50%, 50, 40, walkie-talkie, blue as the sky. We put them on oxygen, and we're able to reverse that in a few hours. If we see that, and this is a message that I want to tell everyone, if you come to our hospital or any hospital, and they tell you we need to send you down to Denver, it's because we do. We know who's local, who's not. We try to keep all local people in our community, and we're getting better and better at that. But the resources we have are the resources we have, and we cannot change a relation. So if you want a faster recovery, if you have a serious incident, and the doctor tells you, we need to send you to Denver, the chances are that you're going to recover in 24 to 48 hours in Denver versus a week in the hospital here. So it's important, Nocturnal oxygen, any of the delivery forms, nasal cannula, oxygenating the room, constitute a new way of adapting to high altitude. And then it's very important because at night is when our bodies relax and we deliver more oxygen to our main organs. They're not distracted in digestion, and doing all the other stuff, and walking around. Your muscles are not taking all that big bulk of oxygen. We can oxygenate the brain, the kidneys, the heart, all the noble organs, okay? Now, we don't engage the same muscles of respiration during the day when we are erect and working than when we are sleeping. So I think the mechanism of respiration at night is different during the day, and that's why during the day you may be studying at 92%, and then you do a sleep study, and at night your oxygen levels go down. So if we can help with maintaining those oxygen levels at night with supplemental oxygen, that's the next day you're going to feel more energetic. You're not going to be sleepy. A lot of people after lunch, they start falling asleep in their chairs. And you're going to have a more relaxing night without waking so much. So my recommendations are the following, see your doctor, talk about your meds and symptoms. There's a lot of medications that we bring from lower altitude to high altitude that can, have issues with your ventilatory system at night. A lot of sleepers, sleep aids. A lot of people are used to those. But then, if we can correct why you wake up at night, that is the low oxygen, you may not need them. And those medications can affect also your ventilation at night, will depress your ventilatory drive, and then, we can get that out of the equation to have better sleep and better oxygenation. Consider nocturnal oxygen. Have your PCP check, your complete blood count at least once a year, and see what those numbers are. Discuss with your primary care physician if you need a sleep study, because we're trying to avoid having issues with your heart in the future. And the need for echo also. We have a really good cardiologist now, Dr. Nelson. I don't know if you heard of her. She's young cardiologist. She's on top of things. She's eager to work with a lot of new patients, Dr. Nelson, Katerina Nelson. And we are going to start conducting a new study in atrial fibrillation at high altitude together. And she's the one reading the echoes up here. So she knows what we are looking for. We are looking for that pulmonary artery pressure numbers and, trying to get people on track and be able to know what's going on with their hearts in the future. And of course, stay active, quit smoking, and eat healthy. Those are my recommendations. And I think we're going to leave the questions for after your guys' presentation.
We'll go fast,
Yeah.
5 minutes.
So this is me happy after summiting 6,150 meters in Peru a couple days ago. That's just for the picture. I was feeling like crap. They were like, "Doctor, look at here." I was like, It was terrible. It was terrible. But I leave my QR code anyway. I do, professional opinions on, I review charts of people coming up or already living here, where I can review all your studies. If you don't have a primary care physician already, and you want a second opinion on what's going on with your stuff, and make some recommendations of what are the things that, hey, you should look into this or that, and maybe make your life up here have better quality of life. Okay? All right, so I leave it to them, and then